Okay, will not go.
Stop share കൊടുക്കും എന്നാ മാറ്റാൻ പറ്റും. Stop share കൊടുക്കും.
പോയതാ. Good morning, everyone. My today's topic for OSCE will be GBS, CIDP and its variants. Myself, Dr. Rohith, and my friend Dr. Hrudya will be presenting under the guidance of Shruti Madam and Kiren sir, this OSCE. So overall, it is 30 questions. We'll go to this first question. See this picture where Guillain-Barré syndrome had a third researcher, but his name disappeared in the future literature. What was his name? Name the three people in this picture from in the order of right to left. Moving on to second question. See this image where arrow is showing a wave in the nerve conduction study. What is the wave indicated by the arrow? What is the importance of this wave in GBS? Next question. Which factor in GBS is least predictive of the occurrence of TRF, treatment-related fluctuation? Presence of a cranial neuropathy at presentation, predominant proximal muscle weakness, patients with diarrhea preceding the onset of GBS, patients with predominant sensory complaints at the presentation. Choose one of the option. Coming to question number 4. Why are certain antibodies like NF155, anti-contactin 1 are resistant to IVIG therapy? Give reasons. Name 4 similar neurological disorders mediated by similar subtype of an antibody. Moving on to next question. A 59-year-old man presented with progressive sensory ataxia, disabling tremor and neuropathic pain. He has IgG4 anti-contactin 1 antibodies compared to NF155. Which feature is the most typical of contactin 1 nodopathy? Options are younger age of onset, association with membranous nephropathy, good immunoglobulin response, poor motor neuropathy. Moving on to next question. Which of the following is true about 2015 Rajaballi revised criteria? The options are: it eliminates the need for sensory studies, it reduces the number of equivocal cases compared to the Ho and Haddon's criteria, it requires at least 3 motor nerves for classification, it relies primarily on the needle EMG findings. Which of it is true? Next question is the case scenario where a 55-year-old man presented with a 1-year history of progressive ataxia and diplopia. He also reported a 5-year history of distal sensory neuropathy of unknown etiology, for which he was attending a neurologist. On examination, there was extraocular movement restriction, as shown in the picture, on a marked gait ataxia with positive Romberg sign, absent vibration sense ankles bilaterally, and diffuse areflexia. His protein electrophoresis showed IgM paraprotein band positive, and anti-GQ1B was negative. What is the next test to confirm the diagnosis, and what is the diagnosis? Next question is a 34-year-old man, painter, presented with progressive sensory motor complaints involving both lower limb followed by upper limbs for 1 year. On examination, there is distal more than proximal weakness with ankle dorsiflexion of 3/5 and hand grip of 4/5 in both lower limbs and upper limbs. Reflexes are absent at ankles and reduced at knees. Rest of it is normal. Sensory distal glove and stocking type of mild numbness was noted. Cranial nerves and autonomic system is normal. On investigation, CSF showed no albuminous cytological dissociation, normal protein. NCS was showing a symmetric length-dependent axonal neuropathy, reduced CMAP and SNAP amplitude. Conduction velocities were normal, no conduction block. The question is, what is the likely diagnosis, and what are the blood or the urine investigations to be tested before making a diagnosis of GB syndrome? Moving on to the next question. Here is a 7-year-old child with recurrent GBS-like episodes and partial response to immunoglobulin. And a partial response to IVIG is found to have absent CD59 on flow cytometry. What is the underlying mechanism in this condition, and what is the definitive management to prevent relapse? Moving on to next question. A 60-year-old man presented with 2-year history of progressive sensory motor complaints. His initial symptoms were painful tingling and burning sensation in the soles of his foot, followed by progressive weakness in bilateral lower extremities and frequent falls. And within 10 months, he was wheelchair bound. He then noted progressive weakness and sensory symptoms in his upper limbs as well. CSF demonstrated albuminous cytological dissociation. He underwent plex, followed by which there was no effect. And then he reported unintentional weight loss of 18 kgs in his due course, and there was progressive darkening of his skin and vascular papilla as shown in the picture. Neurological examination after few months demonstrated worsening of weakness, atrophy, and length-dependent sensory loss in all modalities. NCS showed absent CMAPs and SNAPs from the distal sites. However, CMAP of the axillary and musculocutaneous were present and revealed severely prolonged distal latencies. CBC showed platelet of 6.03 lakhs, and serum protein electrophoresis was normal. So the question is, what will be the next appropriate test, and what is the provisional diagnosis based on this case scenario? Coming to next question, a 55-year-old patient presented with 8 weeks of progressive symmetric proximal and distal weakness, areflexia, and sensory loss. NCS shows demyelinating features, and CSF reveals albuminous cytological dissociation. According to 2021 EA and PNS diagnostic criteria for CIDP, mention one change which was seen in the clinical classification and electrophysiological criteria compared to the 2010 criteria. Next question is, which of the following is not considered the subtype in the 2021 PNS, EA and PNS criteria of CIDP? Sensory predominant CIDP, MADSAM variant, CISP, DADS variant. And why was this excluded? Next question is, a 58-year-old male who presented with severe sensory ataxia and distal weakness. Nerve conduction showed demyelination. Serum immunofixation reveals an IgM paraprotein. Which antigen is most associated with this kind of a neuropathy? Options are GM1 ganglioside, MAG, GD1A ganglioside, sulfatidide. And what is the first line management for this condition? Moving on to next question. Here is a 42-year-old man with no prior comorbidities presented with a left facial weakness treated as Bell's palsy, followed by which after 1 week he had right facial weakness as well. Simultaneously, he noted paresthesias and distal weakness in all his limbs. No prior antecedents, and his EMG showed, and this as shown in this video. What is the EMG finding and when is this noted in GB syndrome? And what are the differential diagnoses for this EMG finding? Next question is a case scenario. 42-year-old female presented with 1-year history of bilateral hand weakness, numbness, and tingling in the right greater than the left upper extremity. And the sensory symptoms involved all fingers, but were most prominent in the ulnar distribution. She as well noted bilateral hand weakness and could not cross her fingers. These symptoms began the day after she started yoga exercises, and one of her family members was also treated for leprosy. She had no rashes or skin lesions, and she was seen by a physician 8 years prior to this presentation and had been told that she had a demyelinating neuropathy and a carpal tunnel syndrome, for which she was treated with plasma exchange IVIG and rituximab later on with poor response. And she underwent nerve biopsy as well, which is showing this. And the questions are, what is the finding in the nerve biopsy and what is the most likely diagnosis and a confirmatory test to confirm the diagnosis? Next questions will be presented by Dr. Hrudya.
Question 16. In 1991, McCann and colleagues reported on the annual summer epidemic of a certain paralytic syndrome among children in rural parts of northern China. The electrophysiology of this illness was different from that of the single variant of GBS that was known at that time. This landmark publication subsequently led to the expansion of the GBS syndrome. Questions are: what was the name given to the disease by the investigators? And which variant of GBS did it lead to the discovery of? Question 17. Identify the variant of CIDP from the description. Inflammatory demyelinating neuropathy, usually affecting the upper limbs first. Lower limbs may become involved later or sometimes are affected from the onset. Cranial nerves including oculomotor, trigeminal, facial, vagal, and hypoglossal nerves are probably more frequently involved than in other CIDP forms. Question number 2 is: what are the various names used to describe this variant? Question 18, to match correctly most common antigen targets and diseases. On the right side, we have Aman, Miller-Fisher syndrome, Canomad, and pharyngocervicobrachial variant. On the left side, we have GT1A, B, GM1 and GD1A, C, diacylosyl ganglioside, and D, GQ1B. Question 19. What are the components of MIGO score? When is MIGO score measured in a case of GBS? What does MIGO score and EGRI score predict? Question 20. Here we have a 52-year-old man acutely develops weakness in all 4 limbs over 2 days, rapidly progressing to complete paralysis and loss of reflexes. Cranial nerve involvement leads to difficulty in swallowing and facial weakness. He requires mechanical ventilation due to respiratory failure. Despite treatment with IVIG for suspected GBS, his condition worsens and he becomes locked in, able only to move his eyes. Anti-ganglioside antibody panel is negative, but anti-neurophysin panel reveals positivity for NF155 and NF186. Questions are: what is the diagnosis? What would be the best management strategy in this case? Which IgG subclass is implicated in this disease? Question 21. A 45-year-old male with no significant past medical history presented with left foot drop and high stepping gait, evolving over 4 months. He reported occasional tingling on the top of the left foot, but with no significant pain. On examination, there is severe weakness in the left ankle dorsiflexion and eversion, mild weakness in ankle inversion and plantar flexion, and absent ankle jerk. There is also diminished sensation over the dorsum of the left foot. Nerve conduction study shows conduction block and temporal dispersion of the left common peroneal nerve proximal to the fibular head, and prolonged distal latencies and reduced conduction velocity in the left tibial nerve. CSF study shows high protein with normal sugar and 2 lymphocytes per hyper field. Questions are: what is the diagnosis? And mention 2 differential diagnoses based on the clinical presentation of the patient. Question 22. Testing of nodal and paranodal antibodies is advised in CIDP patients with the following features except resistance to standard therapy with IVIG and corticosteroids, low frequency tremors, ataxia disproportionate to sensory involvement or other cerebellar features, and normal CSF protein levels. Question 23. Which of the following is not used as a second-line agent after the failure of first-line therapies in CIDP? Cyclophosphamide, efgartigimod alpha, rituximab, mycophenolate mofetil. Second part of the question is, which is the only FDA-approved drug to be used as second-line agent in CIDP after failure of first-line agents? Question 24. The presence of which antibody is most predictive of a poor response to IVIG? Options are anti-myelin associated glycoprotein antibody, anti-neurofacin 155, anti-contactin 1, anti-ganglioside GM1 antibody. Question 25. What was the major finding in CIDP-GBS study? That is second IVIG dose in GBS study. And second part of the question is, there is a statement, you have to mention whether it is true or false. A patient who shows no objective evidence of improvement with IVIG may be tried on plasma exchange according to the 2021 EAN PNS guideline for a case of GBS. Question 26. Based on the latest guidelines, what is the recommended management for an adult GBS patient with mild non-disabling weakness, that is GBS disability score 1, who presents within 2 weeks of symptom onset? Initiate IVIG or PLEX immediately. Do not initiate immunotherapy. Instead, observe closely for progression. Initiate a short low-dose course of IVIG. Initiate high-dose oral corticosteroids. Question 27. In a patient with acute onset pure motor neuropathy, clinically suspected to be AMAN, which specific electrodiagnostic finding would be the most direct evidence of disrupted ionic conduction at the node of Ranvier rather than primary demyelination? Options are prolonged F5 latencies, widespread temporal dispersion, reversible conduction failure, reduced CMAP amplitudes. Question 28. What common widely consumed substance has been shown in multiple epidemiological studies to be associated with a significantly lower risk of developing GBS? Options are caffeine, vitamin C supplements, probiotic yogurt, and cigarette smoking. Question 29. In a case of a patient initially diagnosed as AIDP, acute CIDP is to be considered in all except. Options are marked sensory abnormality including sensory ataxia, absence of facial, bulbar, or respiratory weakness, and slower disease onset, and late reduction in motor nerve conduction velocity. Question 30. According to 2021 guidelines, all of the following are important risk factors at presentation for GBS that predicts mechanical ventilation, except neck flexion weakness, GBS disability score of 4 or more, inability to lift arms above horizontal, and patient presenting after 7 days of onset. Second part of the question is, abnormality in which routine blood test is considered as an important risk factor at presentation.
Sorry, total comes to around 50.
He will have how many marks for 0 to 50.
Each question we have mentioned the marks 1 plus 1. For 15 questions, 40 each.
This variable, 2 in sum and 3 in sum.
So we'll move on to the answers. Question number 1 was, we had seen a picture where it is consisting of 3 researchers, where the third researcher, the name disappeared. What was his name? The name was Andre Stroll, who was credited to carry out electrophysiological tests for the 1916 publication when the GBS was named, and many hypotheses for regarding the non-inclusion because his contribution was limited to the electrodiagnostic studies, and he didn't describe it clinically or CSF findings, and he lost touch with Gillian and Barre, who continued to work together. And broad medical interest of his in physiology and radiology, in addition to the neurology, could have affected his credibility amongst the neurologists at that time. And his age, he was 29-year-old at the time of publication and had been practicing for just 3 years. And last but not the least, he was from Alsace, that is from German there, that is from France. They had an anti-France sentiment at that time. None of these theories were proven, however, but many. So,
That's a summary of everything.
so the 3 researchers were George Charles Gillian, Barre, and then Andre Stroll. So the next question was, what is the wave indicated by the arrow? And what is the importance of this wave in GBS? This wave is A wave. That is the axon reflex wave, which tends to occur before the F wave and after the M response. This can be the earliest finding in GB syndrome, and it is generated by collateral sprouting and apoptic transmission.
How is it different from F wave?
Uh,
Go back and show.
So this is the A wave, this is the F wave. F wave is variable. A wave is more or less non-variable, and it is having a reduced amplitude when compared to the M wave. And it occurs at the same latency period, unlike the F wave.
So both F and A will have reduced amplitude compared to the M wave. The A will be constant. So the one exception is not an A wave. Everywhere else, you are getting a very constant wave with a constant morphology, constant latency. On the other hand, F is variable. When is it seen?
Usually it is seen in the earliest stages, and mostly it is seen in the tibial nerve, as tested. Maybe missed in the other nerves.
What's behind the F wave and then A wave?
Can get it.
Student and other important.
When there is a supramaximal stimulation, this generation of the F wave we can appreciate. That might abolish the A wave as well. When it is a submaximal stimulation only, we get to see this A wave. That is because of the transmission along with the when we stimulate, because of the nerves having a damaged myelin, there can be a transmission between the two nerves and can appear as a axon reflex in the electrophysiology. And that happens when we give a submaximal stimulation rather than a supramaximal stimulation, which get cancelled in a supramaximal stimulation. F wave afferent and afferent is when we stimulate, it transfers the course until the cell body and comes back through the same.
Which structure is afferent and which is efferent? For F.
Both are motor nerve itself.
So it's not a true reflex.
It's not a true reflex. So this question was mark one of the answer, which has the least predictive value of occurrence of in GBS of treatment related fluctuation. The answer was patients with diarrhea preceding the onset of GB syndrome. So the predictors having the highest risk are severe weakness, predominant proximal weakness, cranial nerve involvement at the onset, presence of sensory symptoms at the onset, shorter interval period of presentation from the onset to the initiation of the treatment, less than 7 days, and demyelinating subtype, that is AIDP. The least predictive or the least associated with treatment-related fluctuations are found to be preceding diarrhea, axonal variants, and anti-GM1 antibody positivity.
So all of them are same.
Yeah.
Like diarrhea is usually precedes summer, and GM1 is also seen with axons.
There are multiple references. I have a reference from the Neurology Green Journal, which has got predictor factors. Next question was, why are certain antibodies neurophysin 155 and contactin 1 resistant to IVIG therapy, and name 4 similar disorders? That is because the antibodies neurophysin 155 and contactin 1 are resistant. They belong to IgG4 subgroup of antibodies. And IgG4 typically don't bind to complement, don't bind or upregulate the inhibitory FcRB receptors on the this thing, and they do not recruit the immune cells. So treatment with IVIG may be resistant in IgG4 related disorders, and similar IgG4 related disorders are Musk myasthenia, LGI1, Casper2 related CNS and PNS syndromes, anti-Glon5 related disorders, and anti-DPPX related encephalitis. Next question was, because of its antibody subtype IgG4 may be less responsive to IVIG.
It's not a 1:1 thing. Many of the some of the IgG4 mediated do respond to IVIG, but here actually in our clinical practice they do respond to IVIG. And Glon5 does not respond to anything.
Next question was a 59-year-old man who presented with sensory ataxia, disabling tremor, and neuropathic pain. Compared to N155, which of the features are more typical of anticontactin was the question, and association with membranous nephropathy was the answer. Rest of the questions are not typical of contactin. And as we can see in this table, usual acute presentation is seen with all the neurophysions, especially with the contactin and the N155. And associated distal weakness is also seen with almost all the neurophysions. But associated nephrotic syndrome and its association as a membranous nephropathy is more common with the contactin compared to the other neurophysions. Next question was, what was the true statement with respect to 2015 Rajabali revised criteria? And why did he actually frame a criteria when there was already Ho at Haddon? That was the meaning of this question. The answer to this was to reduce the number of equivocal cases compared to the Ho or Haddon criteria. So after this is the first column is a Ho, then the second is a Haddon and the Rajbali criteria. He actually made more stringent criteria with respect to the conduction velocities and the distal latencies, and added a criteria for Raman which was not well established with the Ho and Haddon, where he told even in if there is even in one nerve there is a distal amplitude reduction less than 10% of the lower limit. If there is an additional demyelinating feature, we can take it as Aman, which was not there in the previous two criteria, and that was leading to a lot of equivocal diagnosis. And later validation studies have shown high sensitivity when compared to that of the Haddon's criteria of 80 to 90 when compared to 50 to 60 in the Haddon and the Ho criteria. Yusuf Rajabali is his full. He's from India.
Birmingham. He's Birmingham.
His full name is Yusuf Rajabali, and he's from Birmingham.
He's from Indonesia or some one of those regions.
This was a case where a patient had progressive ataxia, diplopia, and distal neuropathy of unknown etiology. And examination showed eye movement restriction, marked gait ataxia, and positive rhombus. And they had worked up in the lines of SPEP showing IgM paraprotein band, and anti-GQ1B was negative, suspecting Miller-Fisher variant. And what was the next test to confirm the diagnosis was the question, and what is the diagnosis? The diagnosis here is a chronic ataxic neuropathy with ophthalmoplegia, M protein. And further two tests which we have to do is the anti-ganglioside panel and the cold agglutinins to have the diagnosis of Canomad. And the closed differential will be a sensory CIDP or a Miller-Fisher variant of.
Close differential was 5 years history. Miller-Fisher syndrome is no longer considered. So Miller-Fisher, it looks like a chronic variant of MFS.
So the differentiating factors will be these three things, where in Miller-Fisher it will be IgG anti-GQ1B positivity, and in sensory CIDP we don't have any specific antibody, and paraproteins will be absent in either of the two, Miller-Fisher and sensory, as well present in Canomad. And CSF may show albumin cytological dissociation in Canomad. Mostly it is normal, whereas in MFS and sensory CIDP usually will be associated with raised protein. The next question was again a clinical scenario where a 34-year-old man, painter by occupation, presented with a progressive sensory motor complaints involving both upper limbs and lower limbs, with examination showing distal more than proximal weakness and absent reflexes, and CSF showing normal protein, with the NCS showing a CMAP reduction and as well as SNAP reduction, with conduction velocities being near normal. So this usual mimics of neuropathy, or there can be an acute presentation in a toxic related neuropathy. And in this case, the clue was the patient was a painter, and the other clues were weakness, which was more distal, and reflexes being absent, and only sluggish in knees, absent at ankles. And there was a length dependent pattern of sensory involvement, and NCS was not showing any feature suggestive of demyelination.
So clinically and electrophysiologically, this was an axonal
neuropathy.
Angles were absent.
So the diagnosis would be a toxin-induced neuropathy, probably toluene related neuropathy. In a painter, there can be many toxins which are involved. It can be organic solvents or a heavy metal. Organic solvents like NXane, trichloroethylene, and toluene are known to cause neuropathies, and as well as arsenic, lead, and mercury, which can be seen in various paints. And the next question was, what are the minimum or what are the blood or the urine investigations which has to be done before making the diagnosis of GBS? Important ones are the serum electrolytes, calcium and CPK levels, and blood sugars, which can have weakness, and urine porphyrin and TFT, which are minimum investigations or which has to be done before diagnosing GBS. They can have periodic paralysis. Patients with hypoglycemia are known to have weakness. They can, although their sensorium might be altered, but not all the patients can have altered sensorium. Minimum blood
They
investigations.
usually mimic stroke rather than.
Stroke rather than that.
Not a-
The next question was of a 7-year-old child with absent CD59 who had recurrent GBS-like episodes and partial response to immunoglobulin. So what is the underlying mechanism and what is the definitive management? The diagnosis here is clear. It is CD59, inherited CD59 deficiency, which is autosomal recessive genetic disorder. Or CD59 is that present with the cells which prevent the complement activation. We all know that in the paroxysmal nocturnal hemoglobinuria, where the anchor proteins, which anchors the CD59 to the cells, are deficient. That is a acquired condition. When the protein itself, that is that CD59 deficiency, that complement activation can happen, which can lead to the uncontrolled, meaning which can lead to the damage to the nerves in the form of demyelination. And there can be hemolysis as well. So the clinical features will be severe chronic hemolysis and relapsing peripheral demyelinating neuropathy and recurrent. They can have recurrent ischemic strokes as well. Definitive therapy will be eculizumab. Peculiarity is they partially response or there can be a response to immunoglobulin when being treated.
So if you have a recurrent GBS like presentation in the first decade, and the problem here is that they may respond to immunotherapy. And if you find hemolysis or something, sometimes you attribute to immunoglobulins rather than the primary disease itself.
The next case scenario was of a 60-year-old man who presented with a chronic history of a progressive sensory motor complaints with painful sensation, and CSF also showed albunocytological. Considering probably they would have considered CIDP, and he underwent plex with no effect. And then there was a constitutional symptoms like weight loss and progressive darkening of skin, vascular papule. So with this, and then CBC also showed platelet count of 6.03 lakhs. Considering the next probable diagnosis of paraproteinemias, they did a serum electrophoresis, which was normal. So what question was, what will be the next appropriate test and what's the provisional diagnosis? So with the protein electrophoresis alone, we might not be able to diagnose. The next appropriate tests will be serum immune fixation and the light chain assays, and along with serum VEGF levels. So the diagnosis here will be POEM syndrome, which comprises of polyradicular neuropathy, organomegaly, endocrinopathy, monoclonal plasma cell disorder, and skin changes. Again, not all the features in the acronym will be or are required to make the diagnosis. There are other features which was seen in the case as well. They can have papilledema, extravascular volume overload, and sclerotic bone lesions, as we see in this picture in the X-rays, and thrombocytosis or erythrocytosis. Along with elevated VEGF levels and predisposition towards thrombosis and abnormal PFT. So there can be a Castleman variant of POEM syndrome also, which can just be associated with a clonal plasma cell disorder. So diagnosis here will be POEM syndrome. The next question was again of a patient who presented with 8 weeks history of a progressive symmetric proximal and a distal weakness, areflexia, and sensory loss. NCS showed demyelination, CSF showed albumin-cytological dissociation. Diagnosis would be CIDP. Mainly, the question concentrated on a change which was made in a 2010 to 2021 criteria. There were many changes with respect to electrophysiology and clinical and treatment therapeutic changes. So the electrophysiological changes were for the typical CIDP, the addition was to, they added from the supportive criteria to the required criteria of sensory conduction abnormality in at least 2 sensory nerves. And clinical and as well as therapeutic changes were also made. Clinical, there were atypical CIDP, which was replaced by CIDP variants, and they removed few things, and only 2 levels of diagnostic certainty is there now. That is a CIDP and a possible CIDP. They removed the previous terms like probable, definite, which was there before. And therapy-wise, main thing was the subcutaneous IVIG, which was used in, which can be used in maintenance therapy, which they introduced, and IVIG and IVMP remains the first line and plasma be the second line. The next question was a similar type of a new consideration, which was not, meaning the new change, which was where the subtype was removed from the new criteria of the ENPNS, which of the following was removed? That is, the answer for this would be CISP. The other disorders which were removed along with CISP was autoimmune neuropathies. The reason why they excluded was there was no sufficient evidence to prove the demyelination. That was the main reason. And the CIDP variants according to the new criteria were distal CIDP, multifocal CIDP, that is a MATSAM variant, focal CIDP, motor CIDP, and the sensory CIDP. These are the 5 types as of the new criteria. Then was this question with sensory ataxia, distal weakness, and showing NC showing demyelination. IgM paraprotein was positive. Which of the antigen most associated with this neuropathy? Answer would be MAG. And first line management to this MAG related neuropathy were presented with severe distal sensory ataxia and tremor would be anti-CD20. That is a rituximab. However, the response to either rituximab or any other treatment strategy is poor, and the further escalation of the therapy is yet to be established.
Generally, you can try rituximab or plasma exchange.
And this question where the patient had a left facial weakness followed by right facial weakness with the EMG showing this thing is, what question was, what is the EMG finding? The answer to this would be myokemia. It can be usually seen as an early finding in GBS within 2 to 3 weeks from the onset. And other differential diagnosis should be, in this case where the patient had a facial myokemia, for that thing would be pontine glioma, a multiple sclerosis involving brainstem. It can be seen in GBS like radiculopathy and radiation-induced classic. It's seen in the radiation-induced myelopathy as well. Myokemia as such can be seen in the radiation-induced myelopathy.
So generally, EMG should be normal in the first few days in any acute disease, but myokemia can be present earlier.
The next question was of a 42-year-old female who presented with 1 year history of bilateral hand weakness, numbness, and tingling with the family history of leprosy. And later she was treated for many years with as demyelinating neuropathy, but with having a poor response. And later on due course, they did a biopsy which was showing this finding. The answer to this biopsy finding was a tomocula. And diagnosis confirmation would be by genetic testing. Diagnosis would be HNPP. The clue to this was the patient had the symptoms after starting the yoga exercises. 1. Second, another suspicion should be because the patient had a close contact with leprosy. There can be a monoretous multiplex of presentation with a confluent neuropathy also. So with these two,
There may be a misdiagnosis. Leprosy is not likely there in HNP. This could be a misdiagnosis and the individual nerve pattern of involvement.
Individual nerve pattern of involvement, most prominent in the ulnar distribution, was another clue for this thing. And then this is the diagnosis HNPP and the genetic testing.
Question number 16, it's a historical question. So in 1991, this landmark paper was published. This is the original article, acute motor axonal neuropathy, a frequent cause of acute flaccid paralysis in China. The disease itself was earlier called as Chinese paralytic syndrome, and this led to the led to the recognition of Aman and Amsan as variants of GBS. And the clustering of cases in the rural China during one season was because of Campylobacter jejuni infection. Question 17. This is a description of a particular variant of CIDP and the various names used to describe this variant. So in this particular variant, both upper limbs and lower limbs can be involved, and usually starts in the upper limbs, and there can be involvement of various cranial nerves as well. So the variant is multifocal CIDP, which was initially described by Richard A. Lewis and Austin J. Sumner in this paper. And the various names used for this variant are multifocal demyelinating neuropathy with persistent conduction block, Lewis-Sumner syndrome, and MADSA, multifocal acquired demyelinating sensory and motor neuropathy. Next is a match the following question. Correct answer to this is Aman. The antigens against which antibodies produced most commonly are GM1 and GD1. Miller-Fisher syndrome, it is GQ1B. Canomad, it is disillosyl ganglioside. And in PCB variant of GBS, it is GT1A. Question 19 was about the MIGO score. The components of the MIGO score or the modified Erasmus GBS outcome score are age at onset, which is divided into less than 40, 41 to 60 and more than 60. And then preceding diarrhea, whether it was present or absent. And then MRC sum score, for which the movements tested are in the upper limbs wrist flexion, forearm flexion, and shoulder abduction, and in the lower limbs ankle dorsiflexion, knee extension, and hip flexion. The second part of the question was, when was MIGO score tested? It is tested first at the time of hospital admission and then at 1 week after admission to the hospital. Third part of the question was, what does MIGO score predict? And also, what does ECRIS score predict? MIGO score predicts patient's inability to walk independently at 4 weeks and 6 months. And ECRIS score or Erasmus GBS respiratory insufficiency score predicts a probability of developing respiratory insufficiency within 1 week of admission to the hospital. The question number 20 was a case scenario where a 52-year-old man acutely develops tetraplegia with the cranial nerve involvement and respiratory failure, requiring mechanical ventilation and worsening despite of giving IVIG. And later on, the Neurofescin panel was positive for both NF155 and NF186. The disease is the anti-pan Neurofescin antibody disease. And second part of the question is, what would be the best management strategy? The best management strategy in this case is B-cell depleting agents like rituximab, because the antibody titer is very high in these diseases. So instead of trying to take out the antibody, it will be a better strategy to decrease the antibody production or at the onset itself. So that is the answer to the second question. And third question is, which IgG subclass is implicated in this disease? It was described with IgG1 subclass, but later on IgG3 subclass is also implicated in pan-Neurofescin disease. Initially, plasma exchange can be given, but it should soon follow with the rituximab.
So the thing is that we don't still know what is the correct treatment for autoimmune neuropathy. So they have published multiple papers. They have found that as opposed to routine GBS, the response to IVIG is not either very transient or poor, but it is not that never responds. And maybe pan-Neurofescin responds a little bit better. We don't know. Again, it is all based on few case reports. Secondly, rituximab and steroids seem to do better. And to some extent, plasma exchange seems to do better than IVIG.
Question 21 is a 45-year-old male with a monomelic weakness. There is left foot drop and high stepping gait alone, with the tingling paresthesia on top of the left foot. These are the clinical presentation. On examination, apart from the left ankle dorsiflexion and eversion weakness, we also find there is weakness of ankle inversion and plantar flexion as well, along with absent ankle jerk. Also, NCS shows conduction block and with the temporal dispersion of the left common peroneal nerve, which is proximal to the fibular head. Fibular head is the common site for a conduction block. It is proximal to fibular head, and there is also prolonged distal latencies and reduced conduction velocity in the left tibial nerve as well. And CSF in this case shows high protein, normal sugar, and normal cells. So the diagnosis is focal CIDP, which is supported by the conduction block, which is at a site different from that of the normal site, along with the high protein in CSF and involvement of other nerves in the distribution like tibial nerve also. Differential diagnosis, at least 2 of this will be enough. So the differential diagnosis to be considered are sciatic neuropathy, because both tibial and peroneal nerves are involved. But then there is high protein in CSF and a conduction block in CS, which is against the diagnosis. And L5S1 radiculopathy may also be considered, but there is conduction block in NCS. And the lower lumbosacral plexopathy, excluding this diagnosis, the evidence will be conduction block and sparing of other nerves emerging from the same plexus. Mononeuritis multiplex or two adjacent nerves of only one limb is involved with high protein in CSF and conduction block in NCS in this particular.
Here, can you go back? It's a very interesting case because the conduction blocks tells you that the lesion is exactly there. It is proximal. Anyway, we usually do it as above fibular head and below fibular head. So we can always say that across the fibular head that there is a block. They might have done specific enzyme test to say that it is proximal. So the point is that if you have a conduction block at that region, you know that the lesion is there. But in addition, there is another nerve being affected. So it cannot be just a very proximal lesion like a plexopathy. Because that cannot explain why there is a conduction. There can be multiple mononeuropathy, like, it can be, so tibial nerve is not something which is prone to compression. But there can be multiple mononeuropathy, but again, conduction blocks indicates that it is a possible demyelination. And the etiology is indicated by the high CSF protein, indicating that it might be a focal CIDP variant than other causes of multiple mononeuropathy.
Second, 22nd question is, testing of nodal and paranodal antibodies is advised in CIDP patients with the following features except. The answer is answer D, normal CSF protein, which is the wrong answer here. The nodopathies are to be tested when there is very high CSF protein. So other clues to go for nodopathy testing in these cases will be when it is refractory to standard therapy with IVIG and steroids, acute or subacute, aggressive onset, and with a previous diagnosis of GBS or acute CIDP, low frequency tremors, ataxia that is disproportionate to sensory involvement or other cerebellar features, predominantly distal weakness, respiratory failure and cranial nerve involvement early on in the disease, associated nephrotic syndrome, very high CSF protein level. 23rd question is, which of the following is not used as a second line agent after failure of first line therapy? So here from this 2021 guideline, after the first line therapy, one of the first line therapies, they have failed, like corticosteroids, IVIG or Plex can be tried early on. But when it fails, what we can go for are rituximab, cyclophosphamide or cyclosporin from the guidelines. And recently, this drug called efgartigimod alpha got approved to be used as a second line after the failure of first line therapy in CIDP. So out of these D or first part of the question, the answer is D or mycophenolate mofetil.
When the first line fails, first line, your plasma exchange and IVIG are immunomodulatory therapy. Steroid is a broad spectrum agent. And once that fails, the second step is immunosuppression. The immunosuppression, you want to go for something which acts very fast. So that is why you prefer cyclophosphamide or even rituximab. Efgartigimod is one of the newer agents. It acts, it's a medical plasma exchange rather. It takes on almost all the IgG level. It brings down very rapidly, similar to a plasma exchange. So we don't have it in India as of now, but that is a mechanism of action.
The role of mycophenolate mofetil in CIDP can be used as a maintenance treatment after the patient has had remission with the first line agent. And the second part of the question is, which is the only FDA approved drug for this purpose? The answer to that is efgartigimod alpha and hyaluronidase, which was approved in June 2024. 24th question is, the presence of which antibody is most predictive of a poor response to IVIG? This question, all these anti-MAG, anti-neurofacin 155 and anti-contactin, all of these are has poor response to IVIG, but the presence of anti-MAG antibody is most predictive of a poor response to IVIG. So the answer will be answer A, anti-MAG neuropathy. Question number 25 is, which was the major finding in CIDP-GBS study? So in this study, they looked to see whether adding a second course of IVIG to the patient who were unable to walk independently, whether it had any positive impact. And the result was that it did not improve outcome compared to the single initial course of IVIG.
No, it was a poorer outcome compared. So it was not only that not improve, it increased the mortality. The second course. So it is now put as a harmful agent, second IVH.
And the second part of the question is, a patient who shows no objective evidence of improvement with the one immunomodulatory therapy like IVIG may be tried on plasma exchange. So according to the 2021 guideline, further deterioration despite of IVIG or plasma exchange, there is no evidence for efficacy of switching the immunotherapy to the next immunomodulatory therapy. So the statement is false. Second IVIG dose in GBS study.
So here, if you want to, if there is a failure of one of the first-time therapies, it may be more logical to consider whether there is a nodopathy and shift to a treatment for that rather than switch between IVIG and plasma exchange. That has been shown conclusively that it is not effective. Even now we do that because we don't know patient eventually improves. Many of them do improve. So we hope it is related to our medication.
Yes. This
This
is the
not based on
guideline.
studies. About the GBS data is based on studies. And one more thing, I wonder why there's IVIG everywhere, because they in abroad they use IVIG as a first line for all GBS, all CIDP. That is why everybody is worried about MAC not responding to IVIG.
Based on the latest guideline, what is the recommended management for an adult GBS patient with mild non-disabling weakness presents at 3 weeks of symptom onset? So the answer is in the 2021 guideline. It's clearly mentioned that if patients with presents with mild weakness or patient is stable or very slowly deteriorating, then there is no indication to start on immunomodulatory therapy from 2 to 4 weeks from onset of weakness. The answer to this question is answer B. Do not initiate immunotherapy. Instead, observe closely for progression, as a natural history of mild cases is excellent and risk of treatment may outweigh the benefits. Question 27 is, in pure motor neuropathy suspected to be AMAN, which is the specific electrodiagnostic finding, which is can be the evidence of disrupted ionic conduction at the node of Ranvier rather than primary demyelination. Answer is reversible conduction failure. As is shown in the diagram, this reversible conduction failure with conduction block is a very rapidly reversible finding in NCS. Whilst reduced CMAP amplitude seen in both axonal and demyelinating disorders, RCF is a specific phenomenon which is more suggestive of a nodopathy, and there is no signs of remyelination. Without remyelination, the finding can revert back rapidly. This is the electrophysiological signature of a nodopathy, where the block is due to transient dysfunction at the node of Ranvier rather than the destruction of myelin sheath or demyelination. This question, which is the substance that was found to be associated with a lower risk of developing GBS? The answer is actually answer D, cigarette smoking. While smoking is a major risk factor for countless diseases, several large studies have consistently shown that smokers are about 30 to 50% lower risk of developing GBS. Ulcerative colitis. Ulcer. Ulcerative colitis.
Treatment is
in a case of a patient initially diagnosed as AIDP, acute CIDP is to be considered in all except. So it's an all except question, and the answer to this is D, late reduction in motor nerve conduction velocity. So when is acute CIDP to be considered in a case of GBS is marked sensory abnormality when it is there, absence of facial, bulbar or respiratory weakness, slower disease onset. This threshold is not defined, but possibly more than 2 weeks from onset to nadir, and ultrasound evidence of a widespread peripheral nerve enlargement, early significant reduction in motor nerve conduction velocity. The last question is, in the GBS guidelines, there's a group of clinical indicators that are given as important risk factors at presentation. This include less than 7 days from symptom onset to admission, inability to cough, GBS disability score grade more or equal to 4, inability to lift arm above horizontal, neck flexion weakness, and abnormal LFT at presentation. So the answer to the first question is patient presenting after 7 days of onset. And answer to the second question, that is which blood routine is considered as an important risk factor at presentation, is liver function test. So the reason why LFT derangement is considered as an important risk factor is, first, it can indicate a preceding Campylobacter jejuni infection, suggesting a potentially more severe axonal pathophysiology. And most importantly, it may be indicative of an more intense systemic inflammatory response, portending to a more aggressive disease course. And this obviously indicates a need for closer monitoring for rapid progression, respiratory failure, and complications during treatment. It is not common. Liver enzyme transaminitis.
It is actually there in the main box. I have never noticed it. She had brought it up.
53.
Wow. How many members here? 5 years ago, more than 40. Let's go with questions. 30 questions. More than
30 questions.
All the exams. How many has counted? I don't care. I am not sure all of the exams. Doctor. Is counted. So 5 years, more than 15.
We have come to the end of the session. Thank you for the patient listening.